Welcome to the Improving Healthcare podcast and webinar. That's a regular series brought to you, I'm delighted to say, by our sponsors, Develop Consulting, and they are a trusted healthcare improvement consultancy. They're really specialising in both primary and secondary care. Now, these podcasts offer you practical insights for real change in healthcare. Each episode, we have different guests and we learn more about how healthcare leaders really are implementing that meaningful transformation, improving patient outcomes, developing their people and their processes to go further. Now, if you like our podcast, do make sure you subscribe on whatever platform you listen or watch us on. And to get more industry insights, you can actually go on the QR code there or just visit the Develop Consulting website. That's develop-consulting.co.uk/podcast, and you'll find out more. Hello, my name is Darren Jones. I've been around healthcare for far too many years. Across 3 decades, it spanned advising in healthcare. And today, I am your host, and I will be talking with my guests about the continuous improvement approach to outpatients and outpatient follow-ups. Now, this is a huge topic. It's been set as a real key priority by NHS England over a number of years, the 10-year plan. And I'm going to quote it. It's got an ambition. It says to deliver more urgent care in the community, in people's homes, or through neighbourhood health centres to end hospital outpatients as we know it by 2035. Now, that's going to make big reductions in outpatient appointments between now and then, surely. Now, I'm joined by Healthcare Director from Develop Consulting, Dr Felix Davies, and also our Managing Healthcare Consultant from them, Sajid Khan, who've both got some real expertise and experience in primary and acute and across the piece. Just to contextualise, outpatients takes about 30%, if not a little bit more, of the NHS budget. If it's not working well, it impacts on everything from A&E to ambulances, through to GP practices, right into community care. Felix, introduce yourself, a bit your background, and tell us what you've been seeing in outpatients and what the problems are and what the opportunities are, more importantly.
Great. Thanks, Darren. Thank you for the invitation. So my background is as a clinical psychologist in the NHS before moving into operational roles and ending up as a chief operating officer and a chief executive in a variety of organizations from healthcare to social care. And I've been working in continuous improvement for about 20 years or so. So in terms of outpatients, Darren, as you say, this is a massive area. Huge amount of activity within the NHS comes under the banner of outpatients. So we know, for example, that 80% of elective activity within acute trusts ends in an episode of outpatient care. So it's a huge area, as you say, not just from a financial point of view, but from a capacity and activity point of view as well. Now, over a number of years, NHS England has been setting targets to reduce outpatient activity, and that has had a degree of success, but not achieved the levels that NHS England has hoped for. And perhaps singling out a couple of key initiatives currently that have been pushed by NHS England. So first of all, we have advice and guidance. Now, advice and guidance is around trying to reduce the inflow demand for outpatient activity. So what this involves is GPs having a patient in front of them rather than referring to outpatient clinics to a consultant. They contact them and receive advice and guidance to avoid the need for a referral to acute outpatient care. What's changed recently is that this has gone from being an option available to GPs to being mandated for a number of specialties. And there's a degree of controversy and discussion, shall we say, around that shift. The other area that's been brought into the NHS in England in recent times is patient-initiated follow-up. And what this does is what it says on the tin. Rather than outpatient clinics calling patients back at their own instigation, it's left to the patients to instigate an outpatient follow-up appointment should they see fit. And this is a second big area that NHS England is seeking trusts to expand on. What Sajid and I will come to talk about is, despite having these two initiatives for a period of time, we've not seen a big impact on outpatient activity and that shift that NHS England's looking for. So one of the key themes that we'll be talking about today is it's not so much what you do, but it's how you do it. So a big issue, big problem, but we at Develop Consulting have a number of ideas around how trusts can make a significant way forward with this really important area.
Saj, you've worked in loads of NHS trusts and advised and helped them, but also you've done loads in primary care, so you're kind of seeing another end of this as well. Just touch on your experience a little bit, but give us your take on this.
Hi, thanks, Darren. And again, thanks for the invite. So my name is Sajid Khan, and I am a healthcare management consultant, starting off as a clinical biomedical scientist, and then kind of moved into NHS transformation. I've worked across, like you mentioned, acute trust, primary care, and NHS national programs. And mainly the purpose of my role is helping organizations redesign pathways, improve flow, and really embed continuous improvement. And my work is kind of focused on whole hospital transformational change, including outpatients, from helping them standardize pathways to implement local improvements. And I'm really passionate about turning theory into practical, measurable change. And outpatients is, as you mentioned, one of the biggest levers that we have in elective recovery. And so I'm really looking forward to today's discussion. So in terms of, Felix mentioned there's a lot of guidance out there. NHS England in 2024 issued out some guidance, essentially a bit of a continuous improvement manual, really, that was structured around right place, right process, and right people, which all of those align to continuous improvement. And so the guidance talks about reducing waste in the form of DNAs and short-term cancellations. It talks about addressing unwarranted variation, again, which is in pathways or documentation. And so these principles are really lean classic concepts, which GRIFT or Get It Right First Time organizations are working with and building upon. So they've issued out operational guidance that covers standardized outpatient clinic templates, standardizing follow-ups with checklists, and really providing specialty-specific outpatient guidance. So the solution are out there, right? The challenge is embedding some of these changes with discipline, measurement, and coaching and continuous improvement. Because the problem isn't guidance, it's execution. And so I think there's a bit of work and focus that we'll talk about today around how do we implement that within acute trusts.
Saj, I'll go to you, Felix, because I'm going to be controversial. Who'd have thought it? But I've been around the block a bit as myself, and I can remember nearly 20 years ago when I first came into an NHS board and looking at outpatients, and lots of this stuff was out there then. And I see outpatients almost behaving exactly as they did 20 years ago. And it wasn't good then. And it's not great now. And yet the material's been there. So what are you seeing? Why isn't it changing? We've seen, I know, Saj, you'll perhaps come to this. We've seen huge changes in some primary care settings, GP practices. We've seen real efficiencies coming, but I'm just not feeling it in outpatients. Am I being too harsh?
I don't think so, Darren. I think it's a fair comment. And what I've seen is building on Sajid's point, the execution of continuous improvements varies enormously across the NHS. So we do have some pockets of really excellent continuous improvement execution. However, my view is it's the exception rather than the rule. And all too often, I think that continuous improvement is seen or reduced to a number of very simple concepts, such as plan, do, study, act, and training programs in the likes of PDSA, with a little bit of training for frontline managers, middle managers, and there's a sense of then it's being done or is being done in terms of implementing continuous improvement at an organizational level. So if I give you one example, I've been around acute trusts where I've seen visual management boards. So for those of you watching, listening, who don't know what that is, these are boards which could be analog, hard copy, paper or whiteboards, or digital boards, which are trying to display the work that's been done in that part of the organization, in this case, a hospital. And it's meant to guide the work. It's meant to give instant feedback around who's doing what, where, when, and how, the patient flow, where attention needs to be directed, and so on. So I've been around hospitals where I've seen these visual management boards, and I thought, well, great, they've got something. That's a start. However, what's actually included on those visual management boards is often quite limited, or doesn't really focus on the key priorities and doesn't really guide improvement. Similarly, I've been into control rooms in acute trusts where there's an enormous amount of data displayed on multiple digital monitors, on whiteboards, on pieces of paper, and there's almost an overwhelm of information rather than drawing out the key priority areas to focus on. So as Saj says, it's almost a case of, quite understandably, people don't know what they don't know. So I've seen continuous improvement implemented in the NHS, private sector, charity sector. And it was only when I came to develop consulting where I really saw the full extent of how continuous improvement can and should be implemented. So we have Toyota trained experts. Our CEO was trained at the global Toyota improvement team in Japan, for example. So the depth and breadth of continuous improvement expertise that we have is unrivaled. So when I see what we mean by a visual management board and what I typically see in the NHS is completely chalk and cheese. So I think what tends to happen, to your point, Darren, almost people get lulled into a false sense of security to say, well, we're doing continuous improvement, but unfortunately, it's often only partially done or not done anywhere near as effectively or efficiently as it can and should be done.
Saj, a lot of people, because they get this material, they'll download some material, this is what we're going to do, and then it becomes a tick box exercise, not an actual delivery exercise of genuine improvement.
So Dan, you hit the nail on the head. The thing here is guidance doesn't change systems, behaviors do. And I think this is where it's really important when we talk about continuous improvement. That is the missing operating system, if you imagine, in current acute trust. So, we talk about standardization, but do we really standardize clinical variation? We're talking about reducing unwarranted variation. We talk about waste elimination, visual management, daily management. We have forms of this, but do we do it to the right and correct level to enable and change behaviors, change outcomes, drive actions that provide the outcomes that we want? And so there's a key element around measurement for improvement rather than just measuring everything and anything in scenarios. So these are some of the real backbones of sustainable outpatient transformation that need to happen or that need to be embedded around some of this. And all of this needs to be supported with some real clear coaching frontline teams and guidance provided to those teams to enable them to carry out some of these actions and tasks. I mean, the biggest wins, come from redesigning real follow-up pathways in outpatients, looking at, making sure that we do, effective patient-initiated follow-ups and make sure that they're done properly, looking at advice and guidance that's done consistently across the board, across all conditions, helping standardize follow-up intervals, things like removing just-in-case reviews that we need that we put in place, and really looking at a risk-based stratification around cohort of patients that really need the follow-ups and those that actually don't, and really putting those things into place, because the future model looks radically different to where we are now. And I think until we make some of these changes really happen, we're not going to achieve that 10-year plan by 2035, like you mentioned earlier, because we need to do more in community. We need to do more virtual. We need to do more self-management, encourage more shared care, fewer routine reviews, but more proactive population health management. And I think some of these things are going to drive the change that we need to change our patients by 2035.
Yeah, I mean, I've seen, one of my concerns is that the way this has now been described centrally could see patients just being pushed into primary care willy-nilly because it ticks a box, hits the target, and actually we're just going to create a bigger problem down the road. So can you give us some examples, Felix or Saj, don't mind who goes first, give some real hard examples of what you've been doing now that's seeing genuine results and genuinely making a change for the better, not just for the patients, but also for the staff and the teams that are working in outpatients.
So, Saj, would you like to go first with some of our NHS examples, and then I can share a couple from our international work?
Yeah, definitely. So I guess the key elements here is outpatients is the kind of hidden waiting list. So the challenge that we always hear is capacity, right? So follow-ups often exceed new appointments. So really fixing follow-ups is the fastest way to create some capacity in allowing us to reduce some of the backlog that we've got. So there's some key thoughts here that I just want to get out there. That's the first one. The second one is digital is an enabler, not the solution. So technology amplifies good processes. It doesn't fix bad ones. And so we really need to get under what some of those processes and actions are. Workforce is really central. So we talked about right people, make sure we have the right skill set, and make sure that they have enough guidance and knowledge and expertise to be able to optimize some of those clinical prep and outcomes that we're looking for. And last but not least, we talk about unwarranted variation. The opposite of that is kind of standardization, but that should not be seen as rigidity, because it allows us to be able to free clinicians to really focus on clinical judgment, not admin variation. So there's some key things that we really need to get across to teams and organizations around how we want this to work.
Thanks, Felix. So saying to you, give us an example, and I'm going to then I'll set you up a little bit, Felix. Then give us, because we'll be coming towards the end of this podcast, give us a top tip, the one thing you think people should do straight away that would make a difference. And Saj, I'll give you the same question afterwards.
Okay, sounds good. So well, after you, Saj, you go for it.
Felix, let me just finish. So continuous improvement isn't a toolkit; it's an operating system. So I think the intention here is the interventions that deliver real measurable change in outpatient demand and follow-ups is standardizing follow-up intervals. So and this means remove clinician variation. So we need to explore and understand some of that. Use evidence-based intervals. Build templates in EPR that allow teams to work through effectively to be able to capture that. Hardwire default follow-up rules so people can follow those and make sure we're not giving follow-ups to people that don't need follow-ups. And that'll hopefully reduce some unnecessary follow-ups. We implement, like we mentioned before, patient-initiated follow-ups, clear inclusion, providing clear inclusion and exclusion criteria, patient education materials, because we need to let patients know that only contact us if you need to. Otherwise, you don't need to, and you're fine to go away. And this is the end of your sort of episode of treatment. Providing digital access routes, safety netting, monitoring of conversion rates. We talked about visual management, but do we look at some of this data around how many patient-initiated follow-up conversions we have or don't, and do we tackle that and view that on a daily basis? And really looking at, specialty-based and level dashboards. The other thing is, you mentioned earlier, Felix's advice and guidance. Again, standardizing response templates, rapid turnaround around those, providing shared loops or learning loops, feedback, so we understand what's working, what's not working, and using real images and diagnostics, i.e. technology, to really be able to share, x-rays, blood results, all those things that really provide intel to allow people to be able to make informed judgments. So there's a number of things that we can really work on through some of those things around some of that, I guess.
Felix, I'm not sure he's left you much to say there, has he?
He hasn't really, has he? He's been pretty comprehensive. So I'll pick two things. So I would say, I know you asked for one, Darren, but seeing how greedy Sajid's been, I'll do the same. So point number one, I think is around a phrase that Sajid's already used, but I'll highlight it. So it's measurement for improvement. So we find a lot of the organizations we work with collate a huge amount of data, but often it's not the correct data to measure for improvement. So making sure that there are baseline data in place to cover the whole of the pathway and the key milestones along that pathway. So conversion rates from referral to triage, assessments, treatment and discharge, making sure that's in place, really important. Point number one. Point number two is around the wraparound of those tools and techniques that Sajid's referred to. So call it grip, call it project management, call it a combination of the two. What we find is that our attention to detail about, so exactly who's going to do what, where, when, and how's that going to be measured, making sure there's accountability there, making sure there's also the right level of understanding, knowledge, support in place for people be able to carry out the actions that they've been allocated to. So those would be my two, and then a few quick examples of some case studies. So three brief ones to mention with you. So we work with a large acute trust around transforming their outpatient services across all of their specialties across the organization. So a huge piece of work with hundreds of staff. And what we were able to do was release 40% of staff time to be able to more time to care rather than on low value activity. Abroad, we've worked in a number of countries abroad. So one example in Canada, we worked with an outpatient fracture clinic, and we reduced patient waits there by up to 3 hours. We made sure that we'd got evidence-based scheduling in place. So we used a grid to avoid batching patients in big groups, but have more of a flow of patients coming through the outpatient fracture clinic. And also we had standardized referral processes across the different sites that organization managed. So there was clarity and consistency when staff were working in different parts of the organization. And then the final case study is one from Australia. So we worked with an outpatient service in Australia at a major hospital, and we reduced check-in time. So 92% of staff, patients rather, were waiting less than 3 minutes to check in. So very quick check-in process. We also were able to release 290 hours of additional clinic time and bring that forward for the more important initial appointments rather than the follow-ups where follow-ups weren't needed. And the process is really important. So we had 100% of patients rating their experience at the end of this project as good or better. And we had 84% of patients rate their experience as excellent. So it's really important that staff, patients are very much involved and feel that their voice is heard and that it's a good experience for them as well as a good outcome. So hopefully that gives you a few examples, Darren.
No, it does. I'm going to finish with you, Saj. I'm just going to ask you a really quick question, a bit of a curveball for you, but I know you've done a load of work in primary care around demand and capacity optimization tool and around appropriate appointments. And it's freed up literally millions of GP appointments. What's different with outpatients follow-up and that then? Why aren't we doing that in outpatient? Surely that's the same sort of thing, isn't it?
Yeah, 100%, Darren. And this is where there's some real opportunity to look at some of those things to really understand who and how and why are we providing follow-ups to patients and cohorts. There's in acute trust, we've taken a whole system approach. So we look at outpatient redesign. We do that by mapping end-to-end the process, really identifying variation, getting rid of waste, and really removing unnecessary follow-ups. But we do that by co-designing those standardized techniques with clinicians and really setting up some clear follow-up rules that are then communicated to the team, to the frontline staff, because they're really important because they're the gateway to allowing these to come through and happen and registering and capturing some of these. So really sharing that information and that knowledge with those staff and making sure that our patient-initiated follow-up criteria is agreed upon with the clinicians and is communicated with the staff to be able to make sure that we implement and action that. And then that is followed up with, like Felix mentioned, the right measurement for improvement. So making sure we have the right follow-up ratios, making sure we have the right conversion rates, we provide the right advice and guidance, utilization, data, DNA rates, etc., to be able to do that. I'll give you a real-life example. I did work with a large acute trust in the south around their outpatient department. So when I went there, they had over 3,500 referrals within the system waiting for an appointment. Yeah, in the system. And some of those patients had been waiting over 75 weeks for an appointment. So over a year for waiting for the point of referral from primary care to be given an appointment. And over 6 months, we worked through this process and the ideas that I've just mentioned today. And by the end of it, I'll give you an example of where we got to. So we delivered a single point of care of outpatients. And in that, we'd like a bit of a service center, a patient service center, reducing their 3,000 patient backlog, over 3,000, down to only on the day. So we had 0 referrals over 24 hours waiting within the system. The referral received on day 1 was given an appointment by day 4 after being vetted and managed by consultants and given an appointment. And the only referrals that were within the system were no longer than 24 hours. So from 75 weeks, we'd gone down to 24 hours. We cleared 3,000, a backlog of 3,000 down to on the day, which were roughly between 240 to 250 referrals. And in terms of their percentage of patient contacts or issues being resolved, had risen from 70% to 98%. So some of these things can have real impact because that right first time, they're making sure we have the right people with the right skill set and the right capacity enables all of this flow to happen a lot quicker. And one of the things that we haven't mentioned, I think, which is really important, and is thinking about different ways of operating outpatient appointments. So do we do one-to-many? Or do we have specific core of patients that require one appointment where one person a clinician is able to see many patients of similar scenarios and we're able to clear some of these backlogs quicker? Just some ideas of thinking about how we can reduce the backlog and manage some of this elective care and the challenges around elective care further.
Saj, that's great. We're out of time. Felix, Saj, that's been really great. After 20 years, I'm starting to hear answers to what we're going to do about outpatient follow-up. Thank you for your time. Thank you for listening to this Improving Healthcare podcast and attending the webinar. We've talked about measuring for improvement. Measure us for improvement. Give us a like on if you're on YouTube with a thumbs up, all that kind of thing. There are plenty of other podcasts that Development Consulting have been kind enough to support. You can find that. Go on to the QR code. We really are talking about implementation here, not just bits of paper. So if you want to change your health outcomes, your health team's health outcomes, please just click on. If you'd like more podcasts, again, click on. If you've any burning issues you want us to talk about on a future cast, please get in touch at info@develop-consulting.co.uk. You may even want to come on. Be delighted to talk to you. Thank you again, Felix. Thank you, Saj. And thank you, everyone, for listening. See you next time.